This is Dr. Nicholas Colyvas. I'm a clinical professor at the Department of Orthopaedic Surgery at UCSF. This is a repair technique of a complex medial meniscus tear. The patient is a 32-year-old. He's very active in Ironman competitions, and he has had a previous ACL reconstruction which did very well and resulted in a stable knee. He's not overweight. He has normal alignment. His x-rays were unremarkable. And he sustained this acute twisting injury that resulted in a new medial meniscus tear. Further imaging with MRI on the sagittal showed a radial split component to a tear in his medial meniscus. I like to look at the axial views. Oftentimes you will find the cut goes right through the tear, sometimes not. But in this case, you can clearly see the radial split component in the medial meniscus at the junction of the posterior horn and the mid-body. In addition, on the sagittal views, you can see the complex nature of this tear with multiple planes, and also some medial overload due to the loss of the medial meniscus load sharing. Here we are in the medial compartment of this patient. This is a complex tear. There's multiple planes. We are trephinating it and preparing it, and then a suturing device steadily starts bringing the posterior horn back together, preserving that meniscus in place. The alternative would be a removal of most of that meniscus. Once the posterior horn is reconstructed here, in this case with 2 sutures, we then address the radial split component with one or 2 sutures, maintaining the meniscus volume and providing a secure fixation of the entire meniscus. Postoperatively, this patient underwent the rehab protocol we typically use and returned to biking and swimming as well as running at about 6 months. His last visit with us was 12 months post-op, and he had returned to all of his activities with no pain or swelling or any other symptoms.